Hi there, Michael here. Just before we get into the podcast, a really brief personal fundraising message. I'm running the Lake District 100 kilometres on the 4th of July on behalf of Pancreatic Cancer UK. Pancreatic cancer is a disease with really high mortality rates post-diagnosis. About 50% of all people diagnosed with pancreatic cancer die within 3 months of diagnosis, and only 2% survive beyond 5 years. Now, I'm truly blessed to know someone who has survived beyond that 5-year period. And so this run is, in part, saying thanks and being grateful for that, but also helping to fund the future research that will improve these survival rates. And some of the research is really cool and cutting edge. If you're able to donate, that would be absolutely amazing. The website address is www.justgiving.com/page/Michael-Butcher-1. That's justgiving.com/page/Michael-Butcher-1. Thanks very much. Let's get into the podcast. Gerard, you're the interim CEO of SCIE. What's the one thing that you would want anyone about to enter social care to know about social care before they enter it?
I think the one thing is about its complexity. I mean, the reality is that nobody knows what social care is in the wider public, and everybody expects social care to be free, and that creates a massive mismatch in expectations for people that suddenly get to that point in their life where they're experiencing a particular stage of life where they're suddenly saying, actually, I might need some help or support here, and going, right, where do I go for this? First point will often be the GP, and that's when they will start their entry into a system that they have probably assumed would be free at the point of contact, that would be accessible, and they have no understanding of in the main, and so I think that recognition and to start with, that it's going to be a complex process, and you're coming from a very different place probably to what you thought was the position.
Why do you think that is?
I think people confuse social care with the NHS, and health is something that everybody assumes is free. Yes, you can say technically there are areas like primary care for dental charges where there are some charges, but the NHS in the main is free. And in people's minds, because we have, as individuals, we lead complex lives, and we don't look at things as, oh, it's a system here, or it's a bit of government there, it's something else over there. We just think about ourselves in the main. And so we're looking at it going, oh, it's all one. It's about support, without recognising actually the welfare state, the NHS, social care, all have very different setups and access entry points, so yeah.
I think it's where we sit right now, which is just towards the end of April in 2026, is a really interesting point within social care. And I think in terms of where your organisation is leading a national conversation in line with what Baroness Casey is doing. Let's just help set the scene for those who don't know who you are, who SCIE is, and then let's pick it back up into where you're leading the conversation. So, who are SCIE? What do you do? How do you do it? Who are your stakeholders?
So SCIE's a fairly small charity. It was set up primarily by the government about 20 years ago to provide infrastructure support across the social care sector. So for providers, for frontline staff, for practitioners, for local authorities. Over the last few years, that has changed more, and we stopped being so dependent on government probably 10 years ago. And as a charity, we then focus on 4 key areas of support. So we provide consultancy services, in effect, for local authorities, for care providers, for the charity sector. So for organisations going, actually, how can we do things better? How can we drive up experience? How can we improve access? How can we be more effective? So we provide support in that space. The second area we provide support is training. So we train 3,500 people every year. They might come from local authorities. They might come from providers. There'll be charities in there, particular focuses on areas that are required under the Care Act. So we provide training on mental capacity, or training on safeguarding for newly appointed managers, for example. The third area is our resources, and our resources are you can download them freely on our website. They're not aimed at the public; they're aimed at practitioners, and they're about how can you deliver care better. What should I really be doing? They're also aimed at people that are organising and commissioning care, so local authorities that are buying care on behalf of people for the public, and it's our resources that we're typically known for. So I think 3 million people a year come to our website to access those resources. And then the fourth area that really does bring it all together is our insights work. So as a charity, the income we raise from the work we're doing on consultancy, from the work we're doing on training, we invest that back in the resources. So our resources aren't typically funded in the main. And we invest that back in our insights work, where we can share insights back with the sector. And I keep talking about the sector, but in effect with local authorities, with providers, with commissioners, and with government. So what are we hearing on the ground? How can we do things better? Where are things starting to fall out? What are the new and emerging issues we need to be thinking about? What are the opportunities? So gathering that research, that evidence, that insight to directly change policy. Because it's brilliant when you work with a provider and work with a local authority, and you can see that practical change. When you work with central government and they change a policy, that can impact on hundreds of thousands of us that may be drawing on care and support. So those are the broad areas that SCIE focuses on, Michael.
So it's very much around your, I guess, your discussions at the policy level, I think, where the interface, I think, is most interesting at the moment. Baroness Casey came out, it seems like a lifetime ago, to be honest with you. It's probably only a month or so, saying that social care is at a moment of reckoning and renewal. How much the problem with reckoning and renewal is that they seem to be quite long-term words. That there's a process to go through that is multi-year and even maybe multi-parliament. Do you think that we've got that time?
Politics makes social care complex, doesn't it? Social care is not a vote winner. You only have to look at what happened with Theresa May, wasn't it, and the death tax. So there is a long history of well-meaning but difficulties in actually implementing reform. Anything that moves to a new parliament, to a new administration, and even if it's a different government of the same colour, will reset priorities, which again adds time in, adds in a slowness to drive change. So I think the question then becomes, how do we turn it into a more of a political issue? Because if people don't want to talk about it, if people don't want it on, if politicians want to keep it off the front page because it's not a vote winner, so don't talk about it, then we're unlikely to see change happen quickly. It's only when people understand what social care is and how it will impact on them that we can really drive through probably some of the we can really drive forward some of the change that's needed. And this is a system that is struggling, that hasn't had the levels of investment typically needed. So I think changing the public view of social care is the way that we have to change, that we then change politicians' minds so that, it's not simply in the Department for Health and Social Care, primarily focused on the NHS. And it's great. Some of the individuals working in the department are really committed to social care. But when you're looking at the grand scheme of where departmental focus and budgets are, their priorities probably feel to be more in the NHS and health space. So we need to change that and move social care up the agenda. And I think that brings me back to Baroness Casey. Let's be clear. Yes, things might be slower than you'd ideally like, but this is the only show in town. If we want change, it's really important we get behind this. And I do think there are the approach that Baroness Casey has taken is quite tactical. I think the focus on safeguarding is something that puts a spotlight on a system that doesn't necessarily learn as well as it could do and should do from previous mistakes. So it provides that window into the system that's very helpful as a spotlight. And again, good to see the department has acknowledged and is taking forward some of those areas, with the chief social worker setting up and moving forward a national panel to look at adult safeguarding and put it more on the same footing as we see in children's. But the other two areas that Baroness Casey has focused on and chosen are areas that everybody assumes are health. They're health conditions, but they are conditions that you don't necessarily, they're not lifelong conditions. They're conditions that if you're a member of the public, you can go, actually, that could be me. They're conditions that are in the news that are quite high profile anyway, which makes it easier for the public to engage with them. So I think putting the spotlight on conditions rather than talking about social care in the main, and putting it on conditions that can impact on everyone and that people have a fear of, may help drive forward some of the conversation in a way that if you're talking about social care in the main, or if you're talking about older people, what does that actually mean? It becomes quite theoretical and is quite hard for somebody to go, yeah, I can relate to that. If you talk to somebody about, are they worried about their mum or dad getting dementia? Are they worried about getting dementia? Have they thought about what happens if and when they do? And let's be really clear, you're talking 4 out of 5 people that get to retirement age will draw on social care at some point in their lives. And the chances are the vast majority of them of these individuals are going to be paying for it, and we don't recognise that. So if you start to stand back and go, actually, let's talk about things that impact on us, the chances are the vast majority of the public are going, "Ooh, but that's dementia, that's health, that's free, isn't it?" Yeah, the same with MND.
So the King's Fund did a great bit of policy research on what people think about in terms of what people think of social care. Echoing what you said, to main finding, low public salience was sort of the main outcome. Basically, people do not know what social care is, and they had a really low satisfaction with social care, below satisfaction with the NHS, and also a really low prioritization of it. So they just didn't give it any thought, which, again, echoing back to your points. I'm I'm curious why we think that is the case, given that 4 out of 5 of us, if we, when we get to retirement age, I'm young enough to be able to say if I ever get to retirement age, will say, well, actually, that's something that is going to impact me. In many ways, social care is a majority service. The majority of us will at some point have some form of interaction with it, and yet we just don't engage. Is that because of how the system was designed, or because it's almost like the pension issue? We don't want to talk about the future, and we don't talk about the negatives of it.
I think there are a range of factors. So yes, there are questions around how the system is designed. I mean, was it really designed at all, or have we fallen into this as a system, an approach? And I think we see from the work Baroness Casey's doing, she's going, actually, we need to be thinking about people in the main, not about system, health system, welfare benefits system, social care system. Let's think about people and talk to people about the support they want and need. So there will be aspects of system design. There will be aspects in there that are about awareness and understanding. So if you don't understand what social care is, how are you going to prioritize it? You're not. So that understanding of what social care is important. And then there's part of us as society, and thinking about where we, as individuals in our families, in our communities, are happy having conversations. So, yeah, social care deals with day-to-day activities. You're talking about, feeding people, dressing people, toileting habits. Those aren't necessarily natural conversations that people will sit down and say, actually, I need to have a conversation with you for when I get older, or when there comes a point that I need care and support. Having those conversations about death is uncomfortable, but I'd much rather have that conversation and make sure that everybody knows, my preference is to stay at home as long as possible. That's on the record now. But I also accept that there comes a point where I will need care, and if that can't be provided at home, then yes, I want the highest quality care I can get. But these are not natural conversations that we have in our society, and so there are a number of factors there in terms of the system the system design, the awareness of social care, and also the way we approach things in society, and our reservations and ability to have uncomfortable conversations, then that feed into some of that, I think, Michael.
Right. It's always struck me as unusual that when you have children, you get given that red book with all of the your markers and your midwife appointments and what have you, and then for a year or so that gets filled in religiously, and that is essentially a care plan for your child. It's and then all of a sudden you sort of get to age 4, right? You're in the education system, and the care plan drops out, and if you don't have a touch point with social care or within healthcare, really, you can go the rest of your life till 60, 65, 85 almost. And then all of a sudden, right now I need a care plan which says, this is how I like to eat. This is what I like to do. This is my religious preferences, my end of life preferences, and washing and dressing and all the other stuff that social care providers will recognize. Are you suggesting then that we need to have going back to your point, we need to have the conversation throughout our life about what our preferences are, but we almost need a system that keeps that red book going, and then we track these care preferences throughout our life.
Yeah, so I think we need to be careful about investing time and resource where it might have less impact. I think the red books may have been replaced in the age of digitalization, but I certainly remember them from my 3 children. Some individuals, will have complex care needs and be supported as children, and then they will face a very different environment when they become adults. So the families often talk about a cliff edge that they face when they're transitioning from children's services, where they might get more support, through to adult services, where the support they get may change and may be quite different. But you're exactly right. Once we're then into adulthood, that's that until the point that we need care. And I think it's not necessarily about having that care plan. It's about how do we as society have those conversations so that your next of kin, your partners, your spouses, understand what it is that you want. And if we have some of those conversations, then it's easier to move things forward when something does happen that's a surprise, or when we get to a point where our circumstances change quite significantly. So I think it's what I'm not necessarily saying is that we should be tracking that right the way through for every single adult for that point at which they need care. But there is something about how do we prepare for it. You see individuals that may be retiring, and they will think about the accommodation they want for that particular point of time in their life, without necessarily going, hang on a moment, in 10 years' time, I probably won't want to move again. What's my accommodation need to be like to really support me? And am I moving into something that is going to be a headache and problematic if I want to stay at home in 10 years' time, if my health changes significantly and I need support. So there is how do we plan for that point in our lives when we will need social care, or the majority of us will need social care.
This is possibly an unkind comment. The majority of the people who are going through the later stages of social care right now are sort of 80 years old. That's post-war or born during the sort of the Second World War period. We then have a very different generation in the baby boomer generation coming through, who have historically had very different needs and wants and a very different approach to life than the generation that's gone before. The generation that went before, stiff upper lip, got through the Blitz, war spirit, what have you, and we now have a generation that is, their reference points are the 60s and the 70s. Is this changing conversation a generational change then? And do we think that that baby boomer generation will be more open to it? Because what you're talking about, having, very stereotypically, changing the British culture so that we have these open conversations about how we're feeling and how we want to deal with our later life care, that's stereotypically not an easy conversation for a Brit to be having.
Um, I think, yeah, you're right. It's not stereotypically an easy conversation. Will it become an easier conversation with generational change? I'm not necessarily convinced. I think we can hope that it will be, but I'm not sure my kids would want to talk to me about my toileting habits. So, that's ultimately where we're where we're getting to at some point. So it's never going to be an easy conversation, but it's a necessary conversation. I think what we accept, though, will change. So, the putting up and making do, I think people will have different views about. I do wonder whether that, impacts on feedback on experiences of social care. So if you have a higher level of expectation to start with about what good is like, does that impact then on when you're comparing it with previous years? That said, we have seen massive drop-offs from 10 years ago for people's satisfaction with the NHS as well. So, I do think some of those aspects might change. Our approach is, I can remember 20 years ago, people would be looking at digital and have very different views. So, most people that are now drawing on social care, they were using email, they were using digital systems when they're working. We're past that point as such. I think we're now in a point where increasing numbers of people wear wearable tech. So people have smartwatches, people have smartphones, and so some of the tech developments, I think people will be more open to going, actually, I get how this provides evidence to help keep me safe and lead the life that I want to lead. So I think some of the things that we expect and we are open to will change, though, when it comes to social care.
So with those, so sorry, rephrase my thoughts here. We have people more accepting of different practices. Paper and pen is out the window. That is now gone, and we're now into an age of digital care plans and remote monitoring and fall detection and acoustic monitoring and all manner of gizmos and Internet of Things in care homes, let alone in other individuals' homes. We have a cohort coming through and into care who have an expectation of what social care should be from a financial perspective, but also a delivery of care and what that care looks and feels and is like. And yet we have a system that, I'm going to borrow some words that you put on LinkedIn a while back, that is not integrated, properly valued, or sustainably funded as a system. How do we square that?
With a significant change in the system. So, we know social care doesn't work as a system, but unless people prioritize it, then there's going to be little appetite to change it, because change will cost money. The individuals that are drawing on care and support, and may have stronger views, will they still be voting in the next election? Possibly. But the point at which you experience social care and say, actually, I need this to change, I think you may have less political clout, and therefore it becomes around the families of individuals and thinking, what do I expect? What do I want from a system, and what am I going to get? And having some of that conversation. But ultimately, we have a system with social care where there is not enough resource in the system. Local authorities really struggle with their financial budgets. Social care, and whether it's adults or children's, right at the top for most local authorities. And they are, more people are coming to them for social care. So demand goes up, costs are going up. We know, some of the impact on providers from changes to national insurance, questions and issues around visa. So the staff that work in social care, you can get more at Aldi. And let's be honest, many of our staff are, the majority of our staff are women. We're more likely to have people from different ethnic minority groups. It really it exaggerates inequalities across the country. And I'd like to be in a place where the person that is looking after me feels valued, feels supported, and feels respected by society. And I don't think that is always the case. And I know it's not all about pay, and it's not all about funding and money, but those are important aspects. And you've got a very much a spectrum. There are some amazing homes out there that are they're way of life homes, really, rather than just going, actually, this is about the provision of care. You look at them and go, actually, I might choose to move into one of these if I can. But they cost significant amounts of money that is beyond the reach of many people. And so, seeing what's available, and making sure that we are actually investing and able to support people working in the sector, so more people want to work in the sector. Why can't it be a career that we put on a par with NHS colleagues, for example, or even above? So
We touched briefly there on what's wrong with the system. Very much on a sort of a lack of resources. Ultimately, that comes down to money from the local authority's perspective, which is, as you suggested, and you've then got the private pay element. I think if you talk to providers, what we're seeing is increased complexity and increased levels of need within our individual services. And had the privilege of speaking to Katrina Hall, who runs her dom care service. She's saying that actually, even in the dom care service, then she's seeing people coming to her with more complex needs than 5-10 years ago. So it does seem to be throughout the chain. Is that reflected in conversations with the local authorities themselves, or is this just a provider perception thing, that it's harder than it was before, or are local authorities reinforcing this view that actually needs are higher and demands are higher on them?
Local authorities are absolutely reinforcing that view. They're quite clear that the people that they are seeing have different needs, and do have more complex needs. Yes, they'll still be people with same levels of need, but as a society, we have made massive advances when it comes to healthcare. We have people living with multiple conditions, all kinds of complexities that um, wouldn't be alive 20, 30 years ago. And that is absolutely brilliant. But those individuals are managing multiple health needs, and therefore can have very complex care needs as well. And we as a system are picking that up. So I think local authorities absolutely understand the complexities, and through the assessments that they undertake for an individual as to whether or not somebody qualifies for care. But recognizing the need and being able to do something significant about it is more of a challenge, because ultimately they don't own the purse strings. Their budgets are set by central government.
Mm. So if we were to get to a system that is fully integrated, properly valued, sustainably funded, what does that look like then? I'm really interested also here around your views on
Looks like.
way of life homes.
Yeah. So I think for me, there is, a well-functioning system means that there is far less inequity. So let's be really clear. Your experiences will vary massively depending on where you live. They will vary massively depending on your background. Yeah, you, me, Michael, we will probably get a better experience of care because we are white, than many individuals would that that are from different ethnic minority groups, and that's wrong. It varies massively depending on your other components that help define you and see how you define yourself as an individual. So yeah, these are things where there is inequity built into experience, but there's inequity in access in the first place. So if you know enough about the system, then you will shout about it. I was speaking to somebody, and they were talking about, how they, because they've been through the system before, they know how to challenge the local authority so that they get the funding of care that they think is appropriate. If you don't know how to challenge, then you're not going to challenge. So that there is inequity in access, in experience, and in outcomes at the moment. And I think that gets tackled by a much better funded system of care, but one that has national standards, so everybody is clear about what good quality care looks and feels like, and what we can expect, and that's what we work up from. What we don't want is anything that everybody works down to, and we move to the lowest case denominator as such. But I think that's ultimately what I would like to see from a system.
So now the national care standards, I think I think it was, first of all, surprised many people who aren't involved in social care to hear people talk about that, because, well, surely, so that's what CQC regulate to. Surely there is a fair set of standards. When you say national care standard, what do you actually mean by that, as opposed to our sort of our general level of regulations that we have?
Yeah, so I think the regulations are, they're quite, what the CQC regulates is what should people be doing under the Care Act. I think what I would like to see in the national standards is something that is more useful to the public, that is more useful to providers, and is more useful to local authorities as well, where they're commissioning care and absolutely critical, to help us understand what good looks like, because there is huge inconsistency, and in part that's because people, if you're working in a particular place, you may think what you're doing is quite good, but it's only when you stand back and have that bigger picture and you're seeing elsewhere that you're going, actually, we could be doing this very differently. We could be doing something better here, and thinking about that. So I think that ability to set those standards, particularly where they're based on evidence, where they're based on research, and not just anecdote, would help people understand what to expect from care.
Hmm. Does that mean that, and the history of care is that it essentially came from housing, and because of the advances in healthcare, we now have this situation where it is something very distinct from that. Previously, you got to retirement age, you moved into a care facility of whatever description, you were housed, you were cared for, you died. Now we seem to have this, well, now we not seem, now we do have this very different end of life situation where it's not health, it's not housing, it's something else that is being packaged around that. This would seem to suggest a conversation that says, no, we fundamentally need to move away from social care is housing related and into social care is its own beast.
Yeah. I mean, I think we need to move into a conversation that social care is people related, and health is an aspect, as we've mentioned. Housing is definitely an aspect, but we're complex as individuals, and there are multifaceted aspects that we all hold very close to us, and I think that all plays into the mix. I do think bringing housing and social care together provides significant opportunities. You look at some of the work that's happening up in Hull, for example, where they were children were leaving Hull, being treated out of area. That's not an ideal experience for that child. If your family, if your friends, if your whole community is in a particular part of the city, and then you're shipped off 50 miles away, 100 miles away, where you don't know anybody, that's not pleasant. That's not nice, and it shouldn't really be happening. So the council there, when some of their housing stock's coming up, has invested in turning those into new children's homes, for example. So you've got those opportunities, but you've also got the opportunity to plan better, to take that step back and go, actually, what are the accommodation needs that link to social care for our populations, and think about that more strategically. Where do people want to be supported? Where do people want to access care? Are we just putting them in the biggest city in the middle of the county, or are we looking at other options? And I think the approach to local government reorganisation, where we are seeing significant changes. So most so many local authorities that are providing social care are going to be impacted on this, and they will cease to exist in their current form in before the next election, and there will be new local authorities in their place, and that brings together that bring together the responsibility for social care and for housing, and that's a real opportunity. It's also an opportunity to do things differently and connect better with communities. So one of the things that smaller councils and districts in particular have been very strong on is those relationships with communities, because they're more local. You're going to have more of those contacts. Um, so I think that opportunity to work in local communities, to understand what is it our residents want, how do we actually work with the market to make sure that that's provided, it creates some amazing opportunities to rethink and review our approach to social care in those areas. Of course, it does also introduce risk at any transition.
So it sounds like there's still going to be quite a lot, if not more, government. And I use that phrase quite generally because there's going to be central, there's going to be local authority government involvement in all of this. But there's going to be some government involvement, but still working with a private sector, because we're largely privatized to shape that. I think there was a lot of talk around how the national care standards would support the move to a national care service, as distinct from a national health service. And the concept of a national care service, I don't think has been properly defined yet, and what that looks like. Do you see the private part of the market continuing, or do you see actually the government, in whatever form, local or national, is going to have to take more control of the provision of care in order for this to work in the long term?
Um, I, I think the governments won't even consider a centralised delivery model. The delivery of social care is through the private sector. Yes, there are some significant charity players as well, non-for-profits within that, but it's not the same as health, which is very centralised and has a few. The yes, there are some private providers in the market, but it's just not the same in terms of the massive volume we have of small independent providers in social care that are more rooted in their communities. So I don't think that is a option. I think what we've seen on that from the current government and their commitment to a national care service, it's about addressing inconsistency. I don't think it's about taking over all care provision. I don't think it's about nationalisation. I think it's about creating a clearer system and a fairer system that are underpinned by those consistent standards of care, so people know what to expect.
Yeah. I suppose so thinking back to what we were talking about earlier in terms of less inequality, less inequity within the system, and the funding challenge of getting from where we are now to where we want to get to, we still have we have today a system that is largely funded by the private pay market. I don't think any care home provider, older person care home provider, would argue that the funding that they get from private pay actually just tops up the local authority funding. Do you think that model continues, or do you think that we do end up with a national cost of care that is equalized across everything?
I don't think that we can end up with one national cost of care, even if there was a desire to do it. I don't know if you clocked the Treasury report the other day looking at Northern Ireland and saying actually if they separated some of the connections around pay from the rest of the UK, they would save millions. You will always have that localized conversation around the cost of delivering care, which will vary from place to place. If you are in a rural area and traveling huge miles, then especially at the moment, transport costs, fuel costs rocketed, really hit your bottom line. If you're in a place with where there isn't the workforce, that impacts on how do you attract the workforce. So in some big cities, it's far more competitive, potentially compared with other areas, but the costs of living are more expensive too. So I don't think we can necessarily expect there to be one cost of care. That said, in terms of the difference between privately funded care provision and that is funded by the state, and you are spot on. Most people expect it to be funded by the state, and then they see they're eligible for care under the Care Act, and then they have a financial assessment, and then they get an unpleasant surprise. So the at the moment, private providers are subsidizing care from the state, and I think in the past that has been looked at, that's been accepted, that actually that isn't really right, doesn't feel fair. So you would hope that it does get addressed, Michael?
You would hope it does get addressed is not entirely the ringing endorsement of this government that one might expect.
But it goes back, doesn't it, to, do you want to do something about it? Is it politically in your top list of priorities? And we know social care isn't. The government's agenda is around growth. So we need to connect social care into the growth agenda. It is around NHS discharge. So we need to recognise and reflect on that. But the government's been quite clear about what its priorities are, what its mandate were. And until we move to a point where the electorate are saying, actually, we really do care about social care, then I think we will continue to see what we've had in the past, where governments of whatever colour, whatever administration, find it a political issue that is hot, that is complex and is costly, and therefore one that they don't necessarily want to grapple with and solve.
Do you think, just changing tack completely from the wider politics of this and actually looking at the legislation, 2014 Care Act, which is the legislation that generally we're all governed by, I think it would be fair to say that this is a very flexible piece of legislation that's almost designed to accommodate every single situation. It's an adaptable piece of legislation. Do you think it's appropriate for where we want to get to? Is it too flexible, too adaptable? Or actually, is this the right legislation for us to have in order for us to be on this journey?
I think it was a significant step forward at the time. I think our needs continue to change, and it does provide some of that flexibility. So if we look at the government, it's currently looking at liberty protection safeguards, replacing the deprivation of liberty safeguards, but it's very technical stuff. But ultimately, it's about providing better support at the right time in the right place for individuals, so that people are safe where we may not have mental capacity. So quite complex stuff, but the Care Act still enables us to move some of those things forward, and they're absolutely key. You're never going to catch everything under under one piece of legislation. It becomes very hard. Could it be improved? I've not looked through it and said, "Oh, this is how I'd change it." Is it really delivering its ambition? I'm not convinced. I think there are areas around advocacy, around information, around advice, that will not really living up to the aspiration of the Care Act and what was envisaged there originally.
That's fascinating. The aspirations of the Care Act, and this is a piece of legislation that sort of traipsed over from Labour to the austerity Conservative government. Clearly, and the financial crisis of 2008 had huge impacts, not only on obviously change of government, but also going back to the conversation about sort of resources and cost, that austerity budget, which really stripped local authorities of money, that continues to have an impact going forward. Just going back to what Baroness Casey said, then there's this moment of reckoning and renewal, as well as this wider national conversation. And we're now going to have to go back and look at the aspirations of the care plan and either revisit, readjust, or actually go, we need to rebase ourselves and go back to those.
So I think where Baroness Casey is coming from it is, let's have the conversation with the public around what do they want and expect from care, and raise some of that understanding and interest to start with. And then you are able to design a system that is more integrated, that works better for individuals. The danger of constantly focusing on legislation is that I think governments potentially have a habit of, if you want to signal change, you create a reorganization and you change structures, you change infrastructure as your key markers. And I think that takes considerable time and effort. And we see that at the moment with the changes. We've got change to local government, as I mentioned. We've got massive change in the NHS, and it kind of going back into central government and part of the Department of Health and Social Care. That takes huge energy, huge amounts of resources, and may not actually impact on people's experience, people's access, and the outcomes. And it's those three things that I think we need to keep at the heart of things. It's very easy to focus on legislation as the solution. It doesn't always work. It can become the distraction. So I think the approach that says, let's have conversations with people, let's understand what it wants, and let's design from that basis. And there probably is considerable flex in the Care Act to enable us to get on and do that.
Mm. We've mentioned the NHS quite a few times, and it is very much the dominant institution within the health and social care space. I think one of the biggest shouts from the social care sector is, why can't we have parity between social care and the NHS in terms of even just employee pay rates and some sort of mutual respect between the two employee groups. I'm always surprised at the scale of social care. And we are, I think, 4 times the number of beds as the NHS. I think the workforce is a multiple higher as well. In fact, actually, if you combine if you combine the NHS and the prison service, social care is still 2 times the number of beds. It's, social care as a sector is remarkably huge. I'm going to be deliberately provocative here. Is the NHS part of the problem?
Um, I mean, it's a challenge, isn't it? Because it is a institution that everybody understands and values, which means it's very hard to change because people will feel threatened. Um, the I think I have heard commentary it being called a national hospital service as well. Rather than, there's all kinds of dynamics within the NHS. Where do those acute hospital services sit in the power play compared with community services, etc. And the power imbalances there. Social care is the back door for many hospitals. It's key to discharge, and I think it's through that lens that it is often seen. But if we take it back to individuals and back to people, they have health, housing, welfare, and social care needs. And what we have is a system that is quite siloed and built up deliberately to try and make things easier from a management viewpoint, which doesn't always work for us as individuals that are wanting to access, that are wanting to draw on those services. I do see some green shoots, though. The neighbourhood health models, those provide an opportunity for social care and healthcare really to take a step up and show what they can do when they work together. That's a fantastic opportunity. Yes, too much at the moment is probably driven by a view that GPs lead communities. I'm not convinced that's the case. I think we are much better integrated into our communities in social care than general practice. General practice is part of the communities. We connect well with general practice, but I think we are more integrated than GPs. And I think trying to get that right and think about what is the role of social care, making sure social care has equal voice and value in the room, in the conversations, when those initial decisions are being made, and making sure people with lived experience are in the room because they will call it out, because they are living with the challenges of poorly designed, poorly executed systems on a day-to-day basis. So getting the right people in the right room does provide opportunities, and there are certainly opportunities there with the neighbourhood health models.
It is a fascinating reimagining of our. I wanted to say care, but it's probably probably the best way of describing it. Our society, where we we have acute hospitals in one place, and then we have our community health and our community services, and it's a refocusing of how this community health model, and that's all forms of health, and it's almost Maslow's hierarchy of needs, right? NHS acute hospital break fix over here, but the rest of your needs, your housing, your food, your mental health, and your ongoing support and your actualization is all done within this community model. Just thinking bigger picture in terms of government structure, you've got the Department of Health and Social Care, you've got DHCLG, which deals with housing and, very bizarrely, the funding for local authorities. So policy for social care gets sorted over here in DHSC, but the funding for it is in a completely different body. It sounds like then that we've got to actually as part of this reorganization, we've got to reorganize government as well, and to get them to say, actually, the government structures have got to realign with this new community model.
I mean, it's even more complex than that, isn't it? With government, because you've got children's social care sitting over there in a third department. You've got the Treasury, so the money might go to councils via MHCLG, but the Treasury holds the purse strings over how much is released anyway, including for health and social care. And then you've got number 10 focusing on where do we really want to make the difference? Where do we want to make the investments that will give us the returns that are wanted under the current administration? So it is it's complex. I think the civil servants are well-meaning, and they tend to work quite well certainly at senior levels between governments and different government departments and making those join-ups. I can see arguments for why you change a department and coordinate, but then you end up just having one massive department, bringing lots of things together. I think you create a structural solution, and it's not necessarily the structural solutions that we need. We need better join up. We need better working together, and we need to recognise where decisions are better made locally than being made nationally as well.
So that then goes back to your point around local commissioning, local workforce policy, local funding, which is made quite difficult by the fact that a lot of what is going on in sort of around workforce policy, employment law, national living wage, and national insurance contributions, this discussion for a fair pay agreement and the potential unionization of social care, all of that is much more national and is not local. So how do we achieve that? How do we get more localization if the workforce part of this is being increasingly nationalized, or being dealt with from a national perspective?
I think a lot of those areas that have been identified there and called out are things that if we stand back as a sector, regardless of if we tackle them locally or nationally, we would be going, this is the right thing to do. Do we think that people at the supermarket should be earning more than somebody that is looking after your loved one, my loved one, yourself, myself? No, I value care. I think, so yes, it adds costs. It adds costs, but we should be paying people fairly, regardless of where they live. So I'm less worried about some of those aspects. I do think it comes back to, though, how do you actually ensure we have the national conversation so that there is more resource put into social care, because there is a fundamental mismatch with we talked about health service and its size compared. It's much smaller in size. Its budgets are bigger though. Let's not forget that. So so there is a lot that can happen at a national level that can be helpful on those, but it doesn't stop us locally from planning. It doesn't stop us locally from saying, actually, what are the right systems that work for us in this community? What kind of care do we actually need, given where our residents are and what they want? And people in different areas will have different views. They'll have different needs. And we've got to be able to respond to that. And I think care providers can respond to that because they're local. They understand your communities. Your private care providers are constantly battling to go, actually, can we get, if we've got vacancies, can we get them filled? Who in our community needs them. And it's far easier to make sure you're providing services that the community needs so it chooses you, than providing something that's quite generic or doesn't do what an individual really wants. They will look and think and go, actually, if I've got a choice here, then I'll make that choice and go to a provider that feels as if it meets my needs better.
So we end up with much more intense market shaping conversations, but it has to be it's a multi-party dialogue between the community health provision, the local authorities are sort of coordinating it, and the private providers. Again, an unfair statement. I think I think the default position between private provision and private providers, and local authorities is one of antagonism. They typically don't get on. How do we reset that? Is that, or is it just a question of, here's the framework, you guys are going to have to work together on a local community basis. It has to work.
So I think, sometimes being more connected with your communities can help. If you speak to somebody that's got the statutory responsibility for social care in a local authority, so the Director of Adult Social Services role, if you're a provider in a small unitary, you're likely to know them. You're more likely to know them. You may well have their number. If you're in a big area, you're going to be more disconnected. There will be far more senior management, so there might be an executive director, directors underneath, assistant directors, heads of, and then you're getting into the teams, the engine of supporting care and commissioning care through local authorities and making those decisions. But it means that providers can be very removed from the most senior decision maker. So I think, local can work better. If you are a big county, it can be a real challenge. If you're looking at dom care, if you're looking at residential care, do you have enough resource to be able to have lots of conversations with smaller providers that might provide better quality care, might provide cheaper care, but actually you might be looking at 2 or 3 beds, or are you going to have the conversations with the organisations that can enable you that can provide 100 beds for your residents? So I do think there are some opportunities there that can build those connections that by looking locally. Quite often when it comes to delivery of social care and assessments, local councils structure things by locality teams. When you then stand back and look at commissioning, they have one commissioning plan for the entire local authority, rather than going, actually, do we need local commissioning plans reflecting our local communities and teams. So again, there are opportunities to change how we commission, but we've got to support commissioners. I don't think I have ever met a commissioner that said, "Do you know what, when I left school, I wanted to be a commissioner." It's not a natural job calling. It's a role that people tend to fall into. And so we need to make sure that they're supported. We need to make sure that they feel valued. They're doing a very hard job. And they have gone through a process where it probably felt less like commissioning if you're a provider, and more like procurement. And those are subtleties for many people probably listening to this. But commissioning is a much more open conversation. Procurement is basically going, I'm buying this from you and I want this back in return. Having those relationships, seeing where actually you're going, do you know what? The provider's closest to the resident that's in their whose home is now in their setting, and let's be clear, it is somebody's home. So the provider is closest, but let them do the assessment. They know the person best. We'll trust them. So things like that reset the relationship are quite important. But I think there's got to be a recognition that it's hard for those commissioners too. They are, they have things that are set very defined parameters in which they're working with, and going, how do we do our jobs most effectively? They don't want to be the really difficult person, but unfortunately sometimes they've had to do that in the past. And I think recognizing that it's a conversation, it's a relationship, there needs to be some give and take, and focusing on not just what's the contract say and how many minutes of care somebody's getting. I'm not interested in that. What I want is the outcomes. What I want is care that's high quality, that makes a difference, that supports somebody. That's what we need to be focusing on in those conversations.
And that's going back to your point around bringing people right to the heart of care and making the decisions at a very local level. I suppose the challenge with that, as we have touched on, is that what that's going to do is it's going to require more funding. So therefore, you're having even more conflict between, here's what we're trying to do within our local authority under the Care Act, and we're trying to meet our obligations there, plus all the other associated regulations around care. But at the same time, you've got the local authority budget and their head of finance, who is definitely having the horrible conversations of, we've got a potential section, get this right, section 114 notice?
117.
117. Always
I
get
can't
it.
remember. Yeah, I know it.
Local authorities have to have a balanced budget, and if they don't, there are consequences. And that friction within the local authority, let alone between the local authority and the providers who they're commissioning services from, can feel very intense at the moment. And I think going from where we are now to where we want to get to means that we need to find a way of navigating through that almost.
Yeah, I mean, we do. I mean, relationships are absolutely key. The bringing residents into decision making, and these aspects, yes, they can add costs to it, but they can also decrease costs. They can enable better decisions to be made. And some things that were just wrong. So I spoke to somebody with lived experience, and they were telling me about how they were in a wheelchair, so electric wheelchair, and it broke down, and they tried to contact the organisation, and the organisation went, "Oh, well, our contract says we've got a 72-hour or something like that turnaround time." Possibly might have been okay, but not if you are relying on that piece of equipment, on that piece of kit to 24/7, and certainly not for this individual who was in the middle of London at the time. What you're expecting them to sit there for 3 days until, so, but bringing that person into the conversation about contracts enables better decisions to be made, so that kind of thing doesn't happen. We assume that conversations drive up costs. They don't necessarily. We see that with a lot of the digital kit that goes into local authorities, in areas like Bromley now, where actually it provides the evidence for social workers and for families and people to actually have a more informed conversation about what is needed. So does somebody really need residential care? Do they need double-handed care? Things that we might be more risk averse, especially without the evidence that enables us to make those more informed decisions in conjunction with the person themselves. So it doesn't always mean more costs, although I do accept that actually, the reality is we are in a underfunded system when it comes to social care and the public purse for social care in particular.
Yeah. I it sounds like and I, oh, it sounds like we're in a system where we've got huge challenges. Funding, system reform at a government level and national level, a national conversation. We need to increase local decision making, implement community care, whilst recognizing that means probably moving how the NHS operates. We've got to consider the national care standards and even maybe moving to this national care service. You said right at the start that the only way that this is going to happen is if it gets to the top of political agenda, which means people need to be talking about it. We need to increase public salience, to once again reference the King's Fund. One final question. What can we do, both social care, but also people interacting with it? What can we do to actually make that conversation happen and to start to have those local voices influencing local politics?
Just going back to your previous point first, Michael, you're right. It is Section 114 for finances. 117's the likes of the Mental Health Act and the continuing health care. In terms of what we can do, have conversations. Yeah, the more we speak about our experiences and share our experiences, then the more other friends, families will understand what social care is. At the moment, it's local election time. People will be knocking on doors up and down the country. Ask them about social care. See the panic in somebody's face when they're going, "God, don't really want to talk about this or don't know the answer," But we need to be speaking about it much more openly round our dinner tables, with our families, with our friends, and ultimately build that momentum so that it does become a conversation, so that it does become a point of relevance and a point of reference, with the recognition that something needs to change so that we all get access to the care, we get the quality of the care, and we get the outcomes, the experiences of care that we would all want.
That sounds like a very suitable place to end this conversation, Gerard. That's been great. Thank you so much for your time. If people wanted to get in touch with SCIE and sort of get engaged, find your resources, what's the best way of getting in touch?
Yeah, so Social Care Institute for Excellence. Probably should have said that at the outset rather than just using the acronym. So by all means, Google us for resources. You'll see on there contact email addresses if you want to have a conversation to understand more about any of the work we do, the support we can offer providers, individuals that are looking at training, as well as the resources that we produce. Or if you're interested in supporting us as more broadly, sharing your understanding, your experiences, your learning, do just follow those links on the website and drop us a line.
Brilliant. Gerard, you've been awesome. Thank you so much for your time. Genuinely really appreciate it.
Thank you.
Thanks.
Cheers, Michael.
Bye.